today's session, I'm going to discuss about dental implants. We're all aware that dental implants is the need of the hour right now. It's an in thing. But do you have any idea that these dental implants were used in the ancient time also? The ancient Chinese used to insert small bamboo sticks into the jawbone and try to replace the missing tooth. Egyptians used precious stones and ferrous to replace the missing tooth. But a remarkable advancement take place with the introduction of subperiosteal implant, now which take the support of the basal bone and have an extension coming out of the gingival sulcus to restore a missing tooth. Followed by this, a number of studies were done and titanium implants were introduced, initially in form of blade implant or self-tapping titanium implant. Then a number of researchers study on the ingrowth of bone into the implant, until Brainmark, who find out because of its number of studies on the implant, he inserted a titanium implant into beagle dog and see that it has fused remarkably. Further on, he did a number of studies on biomechanical process that were involved when titanium is placed into the living tissue, and he was the one who introduced the implant to the dentistry world. He is the father of implantologists. He had coined the term osseointegration, which is derived from the Latin word os means bone and integro means renew. Thus, by definition, an implant is a prosthetic device of alloplastic material implanted into the oral tissue beneath the mucosa or periosteal layer and substance that is placed onto or upon the jawbone to provide retention and support for the fixed or removable prosthesis. Now, there are two theories that has been put forward to explain the endosteal implant integration with bone. One is the Brainmark theory of osseointegration, which state that there is a bony union that takes place between the implant and the bone without any intervening fibrous tissue. Wherein on the other hand, Wee's theory of fibro-osseous integration state that there is presence of a fibro-osseous connection between the implant and the bone. And this fibrous tissue is nothing that it is actually that mimics the periodontal ligament in the normal tooth. But currently the Brainmark theory is widely accepted and it is actually true. Thus, what exactly is osseointegration process? Osseointegration is formation of direct interface between the implant and the bone without any intervening soft tissue. There is bone-to-bone contact. There is bone growing over the titanium screw without any kind of soft tissue between them. Now this slide shows a schematic representation of what exactly takes place. First, as soon as you place an implant, since you have drilled a bone and then you placed an implant, there is a reaction, a healing reaction that starts. There is apposition that takes place, which is followed by meso cell migration. Meso cells start to recruit and it gets attached to the implant site and start proliferating. It causes osteoblast differentiation and osteoid formation, which eventually cause the matrix to proliferate and bone remodeling occur in that area. Now, initially we used to use removable partial denture and fixed prosthesis to replace a missing tooth. But why suddenly this craze of using a dental implant? Now what happened as time passes, because of tooth loss, the alveolar ridge also decreases in size, because if the tooth is present, it keeps on moving because of mastication, because of the periodontal ligament, the stresses are distributed. Now this stress is able to maintain the alveolar ridge height. So once the tooth is lost, these stresses are not there. So alveolar ridge height, that is termed as disuse atrophy, take place and the ridge height decrease. But what happens if you replace it with a removable denture? The denture sits on the bone. So when a force is applied, a compressive force acts on the bone. Now this compressive force causes resorption of the alveolar ridge. At the same time, you put clasp on the adjacent tooth which engage into the cervical area. And if the oral hygiene is not maintained, this causes caries formation in the cervical area, and eventually the adjacent tooth also become carious and become loose, periodontally compromised, and you have to extract that and increase the span of the removable denture. Now this was overcome by use of fixed prosthesis. But fixed prosthesis also takes support from the adjacent tooth to bridge that area. Eventually, caries can take place because of marginal leakage of the cement The tooth on which we have put the bridge, it undergo caries, and you eventually have to extract that tooth and increase the span of the fixed prosthesis. Now this was overcome with the introduction of implant. Now implant is actually screwed into the bone. So when masticatory forces are applied onto it, it distributes these forces on the bone. So since the forces are acting on the bone continuously, it doesn't cause a resorption of the bone. Though it doesn't have a periodontal ligament, there is fixed osseointegration, still the stresses are distributed evenly and it maintains the volume as well as the density of the bone. This is how implant is beneficial over the removable partial denture and fixed prosthesis. Now let's move on to the classification of implant. Now based upon the placement within the tissue, implant can be classified as a epiostal implant, wherein they take support from the bone itself, that is they rest on the bone. These are example of subperiostal implant. Okay, then transostal implant. They engage both the outer and the inner cortical plate. Okay, thus they take the support from both the outer and inner cortical plate. Bicortical transosseous implant. Endostal implant. They pierces one cortical plate and they lie in the bone, that is the body of the bone. That is the substance that is in the basal bone. Now endostal implant are of two forms, that is bone form implant, plate or blade form implant. Now this slides show a subperiostal implant, wherein it's actually like a cast partial denture. But cast partial denture you put it on the mucosa, but in this case its framework is subperiostal and you have a projection, vertical projection or abutment that comes out of the gingiva, and top of that you build your prosthesis. Okay, now this slide show you a transosseous implant wherein you pierce the implant through and through. Okay, from the inferior cortex to the superior cortex, and you have a projection that is coming out. So basically the threads are there on the inferior and the superior cortex, and the center part is smooth. These are transosseous implant. In these case, osseointegration doesn't take place. There is actually osseofixation. It's like you fixing a fracture. You're taking the support of the cortical bone. Now we take the support of the cortical bone because cortical bone are resistance to resorption. So it uses that principle, engages both the cortical plate and it gives a good fixation. But there is no osseointegration in this, there is osseofixation in this. Then come to the endostal implant. Here you could see the blade form implant, the cylindrical implant and the root form or screw-driven implants. Now based upon the surface of implant, implant can be classified as smooth surface implant, mechanical surface implant, textured implant and coated implant. Now these implant, depending upon the site that you are placing these implant, these textures are there. Okay, if you're placing the implant in a dense bone, you do not require serrations on it. So you can use a cylindrical implant, that is the anterior mandible, you can use cylindrical implant. If you're using the implant in porous bone, you require serration. So that comes the mechanical surface implant where the serration can engage into the bone. Then the textured implant. If you're using a lesser diameter implant, you need a longer implant. Okay, and they are textured implant which increase the primary stability of the implant, and surface coated implant which are more commonly used in the maxilla because they are more porous. So you need some surface coating to enhance the osseointegration process. Then based upon the loading protocol, implant can be classified into two stage, that is delayed loading or single stage. Single stage is further classified into immediate loading and early loading. Immediate loading is what you place an implant. As soon as you place an implant, you put your immediate is that as you put your implant, you give a prosthesis over it. That is immediately you load the implant. Okay. Early loading is you place the implant and you give the prosthesis 48 to 72 hours after you have placed the implant. That is early loading. In case of immediate loading, you will give a provisional restoration. You will not give a final restoration. That is in case of an anterior teeth. In case of early loading, you will directly give your permanent restoration, but you will give it after 48 to 72 hours. There is a new concept that is termed as progressive loading. Okay. Now, rather than directly subjecting the implant to stresses which will result in implant failure, why not increase the stresses gradually? Okay. Now, you cannot suddenly, if you go to a gym, you start lifting weight, you will start with 5 kg, 10 kg, 15 kg. You will not suddenly pick up 50 kg weight. Okay, that is, you're toning your muscle, you're increasing your muscle bulk. Similarly, you cannot suddenly increase the stress on the implant. You have to progressively increase the stress on it. So in this case, you will load the implant with the prosthesis and ask the patient to have liquid diet. Okay, you have loaded, but still the patient is on liquid diet. Then you will keep the occlusal surface out of occlusion. Then you will give a prosthesis which is in occlusion, but still the patient is on liquid diet for at least 1 or 2 weeks. Then you will keep the prosthesis in occlusion, tell the patient to have soft diet for 1 to 2 weeks. Then after another 1 to 2 weeks, tell the patient to have normal diet. So you are incrementally increasing the stress, that is termed as progressive loading, which is nowadays the current concept of loading the implant. Then, based upon the treatment option, Mish has divided the implant into 5 treatment options. FP1, wherein you replace the crown portion of the tooth with an implant. FP2, where you have to replace the crown and missing root with the implant. FP3 is where you have to restore the crown as well as some amount of soft tissue, that is gingiva in form of pink acrylic when you are giving a prosthesis. Then RP4, these are removable prosthesis, wherein you use an implant supported overdenture, wherein the support is totally from the implant. And RP5 is when the anterior support is from the implant and posterior support is from the soft tissue, that is a hybrid denture. Alright, let's move on to the component of implant system. Now, implant system consists of an implant body. This is that part of implant system that goes inside the patient bone. Now, implant body is further divided into the apical portion, its body proper, and the crestal module. Now, there are different type of crestal module. It could either be square shape, triangular shape, or hexagonal in shape. They say that as you increase the crestal module, the stability increases, because on top of this implant, you're going to fix a cover screw, you're going to fix a healing abutment. So, the more you increase the helix, the better it is, they say. Then you have a cover screw. Now, cover screw is used to cover the occlusal surface of the implant to prevent the overgrowth or the ingrowth of the soft tissue. Then comes the healing abutment. Healing abutment is nothing but a cylindrical portion of the implant of a metal that is fit on top of the implant. Now, this is used to contour the soft tissue or contour the gingiva to have a good emergence profile. Okay, that is the use of a healing abutment. Then come your standard abutment. Your standard abutment is nothing but a connector between your implant and your removable or fixed prosthesis. You will fit this connector either with cement or with screw. It is a connection between the implant and your prosthesis. Then comes your hex driver. Now, hex driver is used to remove the screw and abutment or healing abutment from the implant. Impression coping. Now, impression coping is nothing but it is a stimulator of your standard abutment, which is placed in the patient mouth and impressions are made. Now, this will stimulate the position of the implant from the oral cavity onto the cast. So, you cannot have the patient continuously at your clinic. You have to have a simulated cast. To have a proper position of the implant in the oral cavity, you will put an impression coping and then transfer this impression coping over the cast. Then comes a lab analog. Lab analog is nothing but an implant that will stimulate the implant in the bone onto the cast that goes inside the cast. That is the lab analog. Because your impression coping has to sit on something in the cast, it will sit on the lab analog, which will mimic an implant in the cast. Then let's move on to the patient selection criteria. What are the indication of implant placement? First is the edentulous span. Now, because of the advancement that has been taking place in field of implantology, you could replace a single tooth as well as you could replace the entire upper and lower arch. Now, this depends upon the patient medical condition and the density of the bone. Then the age limit. What is the lower age limit? Once the growth spot is over, once all the permanent teeth are erupted, you could do an implant treatment. Okay, what is the upper age limit? To be frank, there is no upper age limit. As long as the patient is not having any systemic disease, or if the patient is under controlled systemic disease, you could place an implant in a 50-year-old patient, and also you could place an implant in an 80-year-old patient. Now, what is relative contraindication? Smoking is relative contraindication because it delays the healing process. The chances of primary stability getting decreases more. It is not an absolute contraindication, but it is in relative contraindication wherein you have to ask the patient to stop smoking for some time during the healing phase of the implant. Then bruxism, then chronic sinusitis. These are relative contraindications. A controlled medical condition is also a relative contraindication. Absolute contraindications are uncontrolled systemic disease like uncontrolled hypertension, uncontrolled diabetes. Now in these cases the patient is more prone to infections. Okay, so these are absolute contraindication. Patients on osteoporotic patients, patients on bisphosphonate, radiated patients, these are absolute contraindication for implant placement. Let's move on to the intraoral examination. Okay, you need to examine the edentulous ridge span to come to a decision how many implant you need to replace. Normally they say that for every root you have to put an implant. But one thing you can keep in mind that between two implants you should have a minimum of 2 mm of space. Between a tooth and an implant 2 mm of space. Between two implant 1 mm of space. Then when you are checking the edentulous span, check the adjacent tooth how stable they are, whether they need restoration or not. Check the overlying soft tissue. Check for any kind of bone prominence that is present. If the overlying soft tissue is very fibrotic or if it is very fragile, if there is any kind of bony spicules, you have to remove it, do an alveoloplasty. You can also do an alveoloplasty at the time of implant placement. You need not do it beforehand. Also evaluate the occlusion of the patient. You have to see the clearance between the implant because a tooth is lost. There are high chances that the maxillary, if a mandibular tooth is lost, the maxillary tooth will supraerupt. So you have to check the interocclusal space which is present. Okay, check the interocclusal space that is present. Okay, because once a mandible is misplaced, the maxilla will supraerupt. There should be sufficient amount of clearance that is present. If the maxillary tooth is supraerupted, you might have to inform the patient that you have to do an intentional RC to reduce the tooth size because you cannot give a very short crown. You have to have a sufficient amount of height. Alright? Then comes the radiographic examination. Now CBCT is the need of the hour. It not only tells you the amount of the quality of the bone, it tells you the volume of the bone in all the 3 dimensions. It will help you to assess the height of the bone, the width of the bone, which will eventually help you to select the proper width and length of the implant. It will also tells you regarding the position of vital structures like the floor of the nasal cavity, floor of the maxillary sinus, approximation to the inferior alveolar artery. It will also help you to check the density of the bone also and decide your treatment plan. Now, density of the bone play a very important role in success of implant treatment. Now, Mish has divided the bone density into 4 types. D1 is dense compact bone, D2 is dense porous to compact bone, D3 is porous compact bone or coarse trabecular bone, and D4 is fine trabecular bone, very less density, there is no cortical crestal bone. This is a diagrammatic representation. D1 is the dense bone which is more commonly seen in the anterior mandible. D2 is thick cortical bone that is seen in the posterior mandible. D3 and D type of bone, D3 is seen in the anterior maxilla and D4 is more commonly seen in the posterior maxilla. Now this slide shows an implant kit wherein you have number of colored coded drills are present. Okay, on that drills there are marking that will determine the length that you have to go inside. Now before these drill there is one black color pilot drill which is used to create your purchase point and remove the cortical bone. Once you have inserted the pilot drill, then you have your first pointed drill. With your first pointed drill, you will get the length of the implant. Okay, keep in mind that once you have got a length, you cannot increase or decrease it. Okay, because the drill will cause sequential widening. It will not cause the increase in length of your osteotomy. Okay, so first you'll use a pilot drill to create a hole. Then you'll use your taper drill to get the length. Once you have get the length, there are gauges are available in different format. Okay, they are like a probe with marking on it, depth gauge. So you will check the gauge how deep you have gone. Okay, once you have gone to your desired length, it is always better to be little deeper until unless there are no vital structures beneath it. Because we always try to place our implant subcrestally. Because some amount of crestal bone loss will take place with healing. So once you have got your desired length, you have put a bone gauge and seen the length, then you sequentially enlarge the size using wider diameter drills. Okay, start with the lesser diameter and go. If you are using a 4.2 mm implant, you will make your osteotomy around, you can say, 3.8 to 4 mm of osteotomy. That also depend upon the density of the bone. If the bone is very dense, you will make a 4 type osteotomy. If the bone is very soft, just 3.5 diameter drill is sufficient, and then you can just do condensation of the bone. There are instruments available for condensation of the bone, or packing of the, or used to condense the bone into the sinus cavity. In case where you're doing sinus lift procedures, if you have to do an indirect sinus lift, there are instruments that are available which you can pack the bone inside the sinus. Let's move on to the surgical and prosthetic procedure of the implant placement. Now this slide will show you the preoperative photograph of the patient, wherein you can appreciate the edentulous span. On the left side of the patient, we need to replace the second and the first molar region. You always do prepare a diagnostic cast and a diagnostic radiograph. This will help you to stimulate the patient in your lab. Will tell you how much the bone is present, how much is the thickness of the bone and the height of the bone. Once you have prepared your diagnostic cast, on your diagnostic cast you will fabricate your surgical guide. Now surgical guide will help you to make the implant or place the implant parallel to each other and parallel to the adjacent teeth. Okay, it's very important. Now once you have fabricated your surgical guide, you will start with your surgical procedure. Okay, you will give a crestal incision, reflect a mucoperiosteal flap, see the bone. If there is any sharp edges, you will trim it. You will get sufficient width. Once you have done this, you put a surgical guide and mark your purchase point. Once you have marked your purchase point, you will first use your taper drill to get the length of the implant. As you get the length of the implant, put a bone gauge, take an IOPM. Now this will help you to gauge the depth that you have gone inside, as well as help you to see the parallelism with the adjacent tooth. As you can appreciate in the IOPA, it is parallel. Then you sequentially widen your osteotomy, select the implant, place the implant. Once you have placed the implant, put a cover screw on top of it. Then go to your next osteotomy site, put a surgical stent, do a purchase point, do your first initial, that is taper drilling, put a bone gauge, see an IOPM. Take an IOPS, see the parallelism between the two implant and to the adjacent tooth. Once you have done that, do a sequential drilling, widen the implant site, put the implant inside. Put a cover screw, do a primary closure, take an IOPA, see the position of the implant. Always try to place an implant subcrestally because some amount of bone loss will occur. Take an IOPA or an OPG for your documentation. Now comes the second stage surgical protocol. In second stage surgery, if you're doing mandible, you recall the patient after 3 months. If you're doing maxilla, recall the patient after 4 months. In second stage, what we will do is we will remove the cover screw and place a gingival former. Now, why do we need to put a gingival former? As I mentioned earlier, gingival former will fold the mucosa along the gingival former. Okay, it will mold the soft tissue around the tooth so that you have a better emergence profile. So place a gingival former, take an IOPM. Okay, once the healing has occurred, that is after 1 week, recall the patient for final impression. When you're taking a final impression, you will remove the gingival former, put an impression analog, and then take an impression. Now, while you are taking impression for an implant patient, there are 2 techniques that I use: closed tray technique and an open tray technique. Now, closed tray technique are used when you have put a single implant, or if you have put a multiple implant also, but they are in parallel directions. So you could remove it easily. So in that case, you'll use a closed tray technique. But if you have used an open tray technique, it is done in case wherein you have put implant in different direction. In this case, your impression analog are longer. You have to create a hole on the tray so that the impression analog projects out. Once the impression analog projects out, You will remove those impression analogs and then you will retrieve your impression and then place back the impression analog again. That is a open tray technique. Now once you have taken an impression, you will pour the cast. Now this cast will stimulate the patient. Then the area around the implant, you will put some pink acrylic to stimulate the gingiva. You will remove the impression analog. You will place an abutment, suitable abutment for that implant. Okay. Once you have placed the suitable abutment on that implant, you'll do your casting procedure. You'll make a metal cast, you'll check the metal trial, then you will put ceramic on it or porcelain on it and do a wrist trial, check in the patient's mouth. Okay, once it fits properly, you will either cement it or you will screw it out. Now fixed prosthesis can either be cemented or you can screw that. You will always have a hole on the occlusal surface. This hole is initially packed with small piece of cotton and then a composite is built on it. This is that you don't have to break the implant, you just have to remove the composite, unscrew it and remove it. Now what are the surgical complications that can occur? Complication that can occur intraoperatively. Intraoperative complication is like when you are drilling, your speed is too much. Because of your speed, the heat is too much and you're not doing proper irrigation. Because of this heat, the bone cells can die and your implant failure can occur. Okay, your angulation is not proper. You need to check. That's the reason why the surgical guides come into the picture and your OPG that will help you to see the position of the vital structure. You might have damaged the inferior alveolar canal or you might have perforated the nasal floor or the sinus floor because of inappropriate dimension. Okay, then a bone fracture can occur if the crestal bone is very thin. Okay, and you have done your osteotomy and you're going to try to place an implant, sometimes the crestal bone might chip. In that case, rather than doing an osteotomy, you should opt for a ridge split technique, which will not cut the bone, which will expand the bone and preserve the cortical bone on the edges. Now, what are the post-operative complications that can arise? Okay, primary stability failure can occur. There could be a fracture of the, that is bone loss at the crestal area, fracture of the screw and abutment can take place, wound dehiscence can occur. This figure show fracture of the screw, that is the abutment screw and the implant. Here, because the implant are placed in different direction, the stresses are not distributed equally. In that case, implant fracture has occurred. Now, how do you diagnose the complication and manage it? Okay, now wound dehiscence can occur and your gingival or you can say your cover screw might get exposed. Don't be in a hurry to check whether the implant is stable or not. For 3 months, do not touch it. Okay, if you could do a primary closure, do a primary closure again. Okay, some people say remove the cover screw and put a healing abutment, but I would say do not do that, because if you try to manipulate before 3 months or 4 months, there are chances that you might affect the stability of the implant. So let it be like this. And ask the patient to maintain the oral hygiene, keep the area clean, use lot of mouthwash so that the area is clean. And once 3 months are over, recall the patient, remove the cover screw and place a healing abutment. Damage to neurovascular bundle can occur. Once the damage has occurred, you can inform the patient that it has happened. It could be temporary with the neurobion or nerve vision. The nerve regeneration can occur after 3 to 6 months, but it is better to avoid it. Now, how will you avoid it? By taking radiographs and CBCT and using a surgical guide. Then sometime bone fracture can occur. As I mentioned earlier, if the crest or buccal or lingual crest is thin, it might fracture when you are placing the implant or doing osteotomy. So in that case, when you are anticipating that fracture can occur, rather than doing osteotomy, do an expansion. Then soft tissue complications can occur. Your drill might get slipped and can cause lacerations of the soft tissue. Sometime the patient had come to you because of a trauma. So there is both soft tissue and tooth loss as well as the bone loss. So you might have to augment the bone and then at the later stage augment the soft tissue and then plan for the implant placement. There are chances that peri-implantitis can occur. It is nothing but inflammation around the implant. What you need to do is, do not panic, do a thorough curettage in that area. If required, you could use a diode laser at the peri-implant area. Eventual healing can take place and you can go ahead with the loading procedures. With this, I would like to conclude by saying that dental implant is an exciting treatment concept that includes a series of surgical, prosthetic, and periodontal restorative skills. Success and failure of the implant depend upon the health of the patient, the drug that interfere with the osseointegration, the amount of the stress that will put onto the implant and the fixture during fixation. We should keep all this thing in mind before going for a planning implant treatment for a patient.